So I'm Debbie Emerson, Hope Hospice's community health educator and certified dementia specialist. I've been with Hope since 2014 as the facilitator of our family caregiver education program. And in addition to my 30 plus years as a health educator, I have many years of experience as a family caregiver. Our presenter for today is Dr. Kuljeet Multani. Dr. Multani is a palliative care specialist and associate medical director at Hope Hospice. Dr. Multani and I have done this class together in the past, and I'm so grateful that she was willing to do the webinar for us today. So Dr. Multani, just to start off a little bit, could you just tell the group a little bit more about yourself and what you do?
I love doing these classes with you because I truly believe that we have a great partnership, but also that you add so much value to our community when we offer these education series to our folks. So I'm a associate medical director with Hope Hospice since 2013. And I'm also palliative care and of course a hospice doctor. I have been practicing palliative care since 2009. I am also a hospitalist, which basically means I work in the hospital taking care of patients who come in and need to be admitted and cared for any medical problems that they have. So I like to say that I like to see the whole spectrum of patients. Really, it's a continuity of care that I tend to see from time to time. It's when they come into the hospital and they're sick and we care for them, but we also start to understand what really is going on in the background. And then kind of sometimes I end up following them outpatient into their homes and nursing homes and boarding cares and really kind of getting the whole sense of what a wholesome care means for them. So I truly enjoy being a hospitalist, a palliative care doctor, and a hospice doctor.
Okay, thank you. So let me give you a little bit of background for this class and for today's agenda. I was my mom's care partner for about 5 years and fairly intensively for the last 3 years of her life. And even though I'd been a community and family health educator for many years, I knew very little about geriatric health issues and virtually nothing about being a family caregiver. So I had to learn a lot and really fast. One of the things that struck me was how complicated my mom's health issues had become. In the beginning, it was arthritis, vision issues, early dementia, and chronic lung problems due to 60 years of smoking. But by the time she passed away, she suffered from every condition that's listed here on our agenda, and then some. At one time, she was seeing about 8 different specialists, all who wanted to fix her, because that's what doctors do. They're trained to do that. And that's a good thing. They're trained to treat and hopefully cure. But we got to the point that the treatments and medications were worse than the diseases. As a daughter, of course, I just wanted my mom to get better. But she was in her early 90s. And in her case, that wasn't realistic. There was guilt. How could I deny my mom medical care? How could I say no when a specialist said, we can do surgery or we can try chemotherapy? I didn't want to be the evil daughter who wouldn't let her mom get treated. And my emotions clouded my rational thinking. I'm not sure when the metaphorical light bulb went on, but one day I realized that it was time to stop this insanity and focus instead on the quality of her life. At 94, there were a lot of things that just couldn't be fixed. My mom told me that she'd had it with hospitals and doctors. I didn't blame her. So I promised her that there would be no more hospitals, no more invasive treatments, and that I would do whatever it took to keep her comfortable and out of pain. And I was able to keep that promise. My only regret is that we didn't choose this course of action sooner. So that's my experience. But every journey is unique and every situation will be full of tough decisions that only you and your loved one can make together. So today's webinar is all about taking a look at what diseases and medical conditions are common in the elderly, and importantly, what we as care partners can do to be sure that our loved ones are comfortable and free from pain. So as we age, our bodies, our organs, immune systems go through changes, sometimes making us more susceptible to illness. So today, Dr. Multani and I will share information about some of the common conditions and illnesses that we see in the elderly, also known as advanced illness, and look at how they can possibly be prevented, or if not, how they can be treated and managed. Okay, Dr. Multani.
Thank you, Debbie. You know, I have obviously heard your story about your journey with your mom, and I feel like I always want to hear it again and again because I think it's so there's always something new that I learned from that when you talk about it. And I think given my own experience with caregivers who are caring for patients who are just sick with many medical diseases, not just dementia, but I think that journey for us as caregivers can be a lifelong experience that we'll hold in making decisions related to that. So thank you for sharing. I always will feel like I learn something new out of every time when you talk about your experience.
Thank you.
So I wanted to talk about the terms that we use first in medicine. And I feel like as patients and as caregivers, we're going to hear these terms over and over again from our doctors and nurses. And really, very honestly, I think it's unfair to assume from our side that you would know everything. What does acute mean, and what does mortality mean, and what does morbidity mean, and especially in the medicine world. So I wanted to briefly summarize the definitions of these terminologies. So mortality, of course, is related to death. Is how the quantification. So putting a number to a situation and which results in fatality. So somebody dying, anything that is related to mortality, to death is called mortality. Morbidity, on the other hand, is the disease factor. What caused that death, what caused that mortality to happen is morbidity. So it always is related to disease. In terms of diseases could be, well, congestive heart failure led to his mortality, which basically means the morbidity in that was CHF, congestive heart failure, which led to that patient passing. Acute illnesses are those which happen suddenly. They can be for a short period of time, something like pneumonia, urinary tract infection, a heart attack, a stroke, something that has suddenly happened. When it lasts for a longer period of time, and we'll talk about those examples. So that becomes a chronic disease, which is basically diabetes, coronary heart disease, so that dementia, a stroke which lasts and patients do not recover from over a period of time. Those are chronic diseases. It's important to understand that we can have acute diseases happening on top of chronic diseases, which is the typical presentation that we see of patients in the hospitals and outside the hospitals as well. And so a lot of times I do encourage patients and caregivers and doctors, especially the medical team, to consider the big picture. You can have an acute situation on top of a chronic situation. And then there can be other factors which are kind of really influencing that situation. Multi-morbidity is when you have multiple chronic problems. You may have a combination of diabetes plus high blood pressure plus heart disease plus congestive heart failure plus a history of stroke prior plus dementia. It can be a combination of multiple medical problems which have lasted for years. So it's important to remember, therefore, that multi-morbidity in the elderly is approximately 55 to 98% of the population. So at least half of the elderly population to almost all of the elderly population has some multiple medical problems which are influencing how they're doing right now.
Okay, thank you, Dr. Multani. That was really good to have that foundation. It'll help us as we progress. I'm wondering, can you talk a little bit about what we mean by the palliative care perspective?
Exactly. Thank you. So I So palliative care is what I call wholesome, good quality medical care. That's all there is. Palliative care is strictly for pallium is to cloak or to cover. So, so pallium comes from the Italian word, Latin word cloak, and it really means to cover what is already happening. So to cloak, in a sense, the disease that's happening. It's not to say that we put a curtain on it, but it's more to say to comfort during a time when you know the disease cannot be treated or fixed or cured, essentially. So in palliative care, we address the whole person. It's providing wholesome medical care, but it's not just physical. It's not just mental. It's emotional, it's spiritual, it's psychological. It's what we call psychosocial care. And most importantly for me, and I'm a very strong advocate of that, it's about personal wishes or preferences for the patient as to how they would actually like to be treated. So it's always the big picture in my mind versus what I'm seeing in the moment at this very time.
Okay, thank you. Okay, I'm going to talk a little bit about something called medication-related problems. And this is really common among the elderly. It's been said that any symptom in an elderly patient should be considered a drug side effect until proved otherwise. 1/4 of all admissions to a skilled nursing facility are due in part to the inability to take medications correctly. That's a lot. One of the big issues with the elderly is something called polypharmacy. And often people are taking multiple medications. And here we're not only talking about meds prescribed by our physicians, but all of those over-the-counter meds, supplements, and herbals that in many cases we decide to take on our own. Medical marijuana, cannabis, is legal and doesn't need a prescription in California or many other states. So please let your physician know if your loved one is using cannabis or products with CBD, cannabidiol. We tend to think CBD is pretty safe, and it actually is, because it's over the counter and it's in pretty much everything these days. But it can have adverse reactions if taken with certain medications. And I'm going to show you a tool a little bit later for checking this. And by the way, just because something is labeled all natural, it doesn't mean it's safe, especially when combined with other medications. So with all of these meds, we're bound to experience adverse reactions, unpleasant or even life-threatening side effects, and drug interactions when 2 or more meds interact with one another, either produces a heightened effect or renders one of the meds ineffective. Another common medication for the elderly is when the dosage is too high. As we age, our bodies process and react to medications differently. For example, kidneys and the liver, which are natural filters for our body, may no longer process medications efficiently. A normal dose of a medication may be an overdose for an elderly person. And then on the other hand, a dose that's too low isn't going to do its job. We also have to look at challenges to compliance or difficulty taking medication. These can include memory issues, dexterity issues. Opening those little childproof bottles isn't easy for anyone. And if they tell you to break the pills in half, not so easy either. Some may be unable to read the labels, both on the prescription meds and over-the-counter meds. And I swear, it's not me, it's not my eyes, but I swear they're making that print smaller. Hearing loss can interfere with the person's ability to hear instructions. And some may have difficulty actually taking the meds, swallowing, especially if the pills are large or if they're taking several prescriptions. So with regards to medication-related problems, what should we take a look at? So the effects of meds can directly impact the daily functioning of the elderly. And so as care partners, we need to be especially observant with regard to medication side effects. If any of these symptoms on the list here appear suddenly, in particular after a new medication or an herbal, they should be considered to be a red flag that a medication-related problem may be occurring. So we're going to look for excessive drowsiness, confusion or disorientation, depression, insomnia, incontinence, muscle weakness, shakiness, tremors, loss of appetite, falls, and changes in speech and memory. Now, of course, all of these can be indicators of disease, but one of the key things to look for is if the symptom appears very suddenly. So I remember that after her heart attack, my mom was prescribed a statin to lower her cholesterol. And this was a new med for her. So a couple of days, maybe a week or so after she started taking Lipitor, she experienced confusion and extreme muscle weakness to the extent that she could barely get herself to the bathroom. I called her physician to check on this and specifically asked if the symptoms could be due to Lipitor. And by the way, this was over 10 years ago that this happened. He told me that it wasn't likely and suggested a series of diagnostic tests to find out what was causing the muscle weakness. And because I didn't know any better at the time, we went ahead with some pretty invasive and uncomfortable tests that all turned out to be negative. I finally went with my gut and insisted that Lipitor be stopped. And her muscle weakness went away, and all the other symptoms went away. So I've said this in my other webinars, as family caregivers, we are a crucial part of the care team. We know our loved one better than anyone else. So don't be hesitant or shy in expressing your opinions. You're actually your loved one's best advocate. So I have an article listed on your resource list. It's called The Caregiver's Guide to Medication and Aging. And it provides excellent guidance for caregivers who are responsible for managing their loved one's meds. So what do we mean by this medication management? It's the caregiver's job, responsibility, to manage and administer medications, meaning in most cases, it's our responsibility to ensure that the meds are taken in the right amount, at the correct times, they're stored appropriately and safely, especially if your care recipient has dementia. And all of this may mean that you need to use some kind of a pill organizer. They come in all shapes and sizes, from the simple little plastic ones to the more high-tech ones that not only dispense the meds from locked compartments, but they'll let you know if doses are missed by pinging you on your cell phone. You're probably going to be the responsible party in getting prescriptions filled and refilled in a timely manner so that no doses are missed. And as we talked about in the previous slide, you always need to be on the lookout for any symptoms of medication-related problems. Remember, any symptom should be considered to be a medication-related problem until proved otherwise. When symptoms interfere with daily functioning, the healthcare professional needs to be informed immediately. So it's so important, again, that you supervise the use of over-the-counter meds, herbals, and supplements to be sure that they don't cause any adverse interactions with prescription meds or even just on their own. I remember I started taking turmeric a while back because I thought, oh, this is good for inflammation. And after about a month, it was starting to wreak havoc with my digestive tract. So it was like, that may not be the med for me, or the herbal for me, rather. So remember, when we're looking at herbals, this includes cannabis or CBD. Let me give you another example. So Warfarin, I'm sure you've heard of that. It's an anticoagulant. It reduces blood clotting. But so is ginger, which is a natural plant. And it can act as an anti-inflammatory. Some people take it to help with arthritis pain. But you want to be sure to let your physician know and your pharmacist if you're taking both, because the ginger could cause excessive anticoagulation. It could cause your blood not to clot properly. So the changes that occur with aging make medication-related problems more likely. However, they can be prevented, especially if the family caregiver works together with the patient's physician and the pharmacist. Caregivers should let the pharmacist and physician know about any obstacles to compliance, concerns about dosage being too high or too low, and of course, any adverse reactions that you suspect. So on the next slide, so how do we know all this? So the next slide, I'm going to show you a tool that can help you with this. So this is one of my favorite resources for anything related to medications. It's called Medscape. And the site is designed to serve physicians and healthcare professionals, but I found that it is really user-friendly and easy for the layperson to understand. So the URL that I have listed here is also on your resource list. And the URL that I have listed goes directly to the Drugs and Diseases homepage of Medscape. So this link here provides information about drugs, over-the-counter meds, and herbals, over 8,000 of them. And it also contains information about a wide variety of diseases and other medical conditions. But my favorite tool is the drug interaction checker. It's really easy to use. If you or your loved one takes herbal supplements, be sure to check on this and see if they're safe to use with your prescriptions. Again, I have the Medscape website listed on your online resource lists. And you may have to create an account, but it's free, so not a big deal. Okay, and then my last slide for a while, I do want to talk about vaccinations, because one of your responsibilities is to ensure that your loved one gets all of the necessary vaccinations. And as a care partner, it's equally important that you stay current on your preventative care, especially vaccinations. So let's take a look at 4 that are recommended for the elderly. People over the age of 65 should get the pneumococcal vaccine, Pneumovax 23, in order to reduce the risk of contracting pneumonia. Now, it protects against 23 strains of bacteria that cause pneumonia, but it won't protect against pneumonia that's caused by viral or fungal infections. Prior to November 2020, most people over 65 got Prevnar 13, and then a year later got Pneumovax 23. But last November, the CDC stopped routinely recommending that people over the age of 65 get both of them, that Pneumovax 23 should suffice unless they have an immunocompromising condition. But it's important, the need for one or both should always be discussed with your physician. And good news, Medicare Part B covers 100% of the cost of these. Now, everyone should get a flu shot, but people over 65 should get a higher dose vaccination. It's called Fluzone, and it protects against 4 strains of the flu. As you know, flu shots are necessary every year to give you some protection, and all insurances are going to cover the cost, and most of them without a copay. And typically, the influenza vaccine reduces the chance of illness by 40 to 60%. I was surprised at that because it seems, especially since we've been talking all about COVID and how, oh yay, it's 95% effective, like, oh, flu, only 40 to 60%. But it's better than nothing. And also the flu vaccine, even if you do happen to get it, your symptoms are going to be milder, even if you hadn't taken it. So of course, the COVID vaccines are what's on everyone's mind these days. Ultimately, these vaccines will be available to everyone. That's happening sooner and sooner, kind of like the flu vaccine. But until further studies are done, right now the COVID vaccine is recommended for those 16 and over. So we currently have 3 vaccines in the US that have received authorization by the FDA. We have Pfizer and Moderna. Both are 2 doses, and both are more than 94% effective in preventing serious illness and hospitalization. Johnson & Johnson is just 1 dose and has an effective rate of about 74%. But, and here's what's really important, it's also extremely effective in keeping people out of the hospital. In fact, all 3 of these have been said to be 100% or close to 100% effective in keeping us out of the hospital, and that's really important. Now, studies are being conducted about how long immunity lasts, but from what I've read, it seems possible that the COVID vaccine may be like the flu shot, and that we'll need it annually. And possibly, like some other vaccines, we may need a booster. However, research is still being conducted on all of this. And then the last one we'll look at is shingles. And shingles is sneaky. It's caused by the same virus as chickenpox, varicella zoster, which lays dormant for decades in the body, ready to pounce when our immune systems are weakened by stress, by medication, disease, or age. So in the US, 1 in 3 people will get shingles, usually after the age of 50. Shingles' most common symptom is an angry, painful, blistering rash. And some people can develop complications that last for months or even years. According to a professor of infectious diseases, shingles rarely kills you, but it can make you wish that you were dead. Now, there used to be a 1-dose shingles vaccine, Zostavax, but that's been replaced by a much more effective 2-dose vaccine. So Shingrix is 97% successful at preventing shingles in people in their 50s and 60s, and 91% effective for those in their 70s and older. Now, Shingrix can have unpleasant side effects. I know I was miserable for about 4 days afterwards. The other unpleasant side effect, just so you know, is that insurance doesn't cover it completely. It depends on your insurance plan. But some have very high copays. Mine was over $200, and I thought I had a pretty good Medicare Part D drug plan. So again, be sure that your loved one is current on their vaccinations and that you are too. Okay, enough of me. Next, Dr. Multani is going to talk about some of the more common conditions that affect the elderly, also known as advanced illness. So Dr. Multani.
Thank you, Debbie. So I want to talk first about congestive heart failure because I think that this is a very common disease that we see in the elderly. And I do get the sense that a lot of people are actually confused about what came first. Congestive heart failure, how did this happen? And then we'll talk about, well, you've got this problem like diabetes or high blood pressure or heart disease. And sometimes it really is a classic example of what came first, like the chicken or the egg, right? Like you don't know which one's first. And then we're talking in our medical mind about like, oh, this acute condition which happened on top of all these chronic conditions, which we think that the patient has. And so it can be really confusing. It can be confusing for families to understand how this actually happened when they didn't even like sniff it or smell it. So CHF, congestive heart failure, is a chronic progressive condition in which the heart muscle is weak and therefore unable to pump enough blood to meet the body needs for blood and oxygen. What does that mean? So if you have a heart which is functioning and it's pumping, and this is the regular, this is your heartbeat if you can imagine. So this is the way the heart pumps. And when the heart pumps, it squishes out blood and sends it to the rest of the body, oxygenated blood. And then it, of course, collects blood back, which is unoxygenated, and then fills it up with oxygen and then pumps out good blood all over again. Now, when the heart, which is functioning and pumping like this, starts to become this, so it's really not pumping optimally. There's a lot of what we call backup and therefore fluid collection and fluid overload, which therefore leads to the problem called CHF. So how do you know that and there are different forms of CHF. There's a systolic congestive heart failure that you'll hear about. There is a diastolic congestive heart failure that you'll hear about. And then there's a mixed CHF that you might hear about. Many different reasons, we'll talk about that in a bit. Well, what do you really go through when you experience congestive heart failure? These are the things to look out for. Suddenly, you're noticing that this patient is more tired than usual. He's not walking around too much. The 2-mile walk is now becoming like a 1 mile or even a quarter mile, and where they have to stop because they're short of breath. And they have to catch their breath and before they start to go up again and work out. Edema, you'll start to see swelling in the legs, more specifically. For patients who are more sedentary, more bedbound, you'll start to see that the swelling is really in their legs, in their thighs, maybe even their buttock area and their belly area, something which we call classic sheet marks. I always kind of lift up patients' gowns to see if that is something that's been going on, because when I can see the sheet marks out there, and then I can understand that that congestive heart failure is just more serious than we thought it was initially. A rapid heart rate. Now, there is a connection of CHF with irregular heart rhythms, something like atrial fibrillation, and we can talk about that in details towards the end if we have time. But you can start to feel palpitations. You start to feel your heart skip a beat, weakness, dizziness, lightheadedness. You just don't feel like you're getting enough blood in your body, which is so it's making you weak, it's making you lightheaded. Blood pressure is going up and down. A weight gain, which is all false weight gain, of course. We always ask our patients who have a history of CHF, especially if it is not well controlled, to monitor their daily weights every day, first thing on the scale, naked. Uh, Monitoring your weight and keeping a log of it is important. So, more than 2 pounds a day or 4 pounds a week. This can be relative. I want to say that because I think every patient is different. So even a weight gain of 1 pound can be significant for somebody who's more a smaller person than somebody who's actually a bigger person and may not really experience anything with 3 or 4 pounds of weight gain. A new cough. This cough is especially dry. I do not really see productive cough, like you're not bringing out phlegm in this cough. This cough is also a very clear cough. If you are bringing up like froth, if you're bringing out froth, it's mostly clear. But usually it's a dry cough. It's also a cough which when you lie down at night, it wakes you up and you're forced to kind of get up again and cough up because and then the second thing is you're not able to lie down fully flat in your bed and you find yourself like propping up a couple of pillows or you're in a recliner and you're actually sitting up and sleeping in your recliner all night long. Next slide.
Okay.
So what are the complications? So the complications can be so either or. So the irregular heart rhythm, the enlarged heart, the heart attack can actually cause congestive heart failure, and then in return, CHF can cause all of these problems to happen. So an irregular heart rhythm, like I described, is something which is called a simpler, non-fatal heart rhythm is atrial fibrillation, something which is less complicated than a dangerous heart rhythm, what we call ventricular fibrillation, VFib, or ventricular tachycardia. So the irregular heart rhythm is really a way of, so it's trying to push this heart to beat really fast when it's actually so weak and flaccid that it really can't pump. And that can cause the patient to feel lightheaded, palpitations, dizzy, chest pain, and can come into the hospital for this. An enlarged heart. So you've got this swollen, boggy heart is how I describe it. The heart muscles are trying to compensate by the lack of pushing by building stronger muscles. These are buff muscles which are actually not doing any good to the heart in general. So you can have an enlarged heart, something which is also so doctors may describe it in different terms, but this is what you can see. And you'll see it on the study called a 2D echo a lot of times. A heart attack. If the blood flow isn't optimal, any lack of blood supply to the proper parts of the heart can actually cause a sluggishness of the blood flow, can cause more of blood clot formation and also end up causing a heart attack activations. And now with a heart attack, you've got a weakened heart, which is now going to make things worse in terms of congestive heart failure. So it is what I call a vicious cycle. You're just kind of going round and round with this. And this is the classic trajectory of what we see in our patients in the hospital and outside. At some point, no medicine's working. You're developing more complications. You need to be on more medications. You have side effects from those medications. You have more issues coming up from multiple comorbidities adding up to this one diagnosis. So it can be a pretty vicious and disheartening cycle. So the treatment for it, of course, is always, always, always number one on my list: food, 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 food. So diet, good food, healthy food, nutritious food, always number one on my list. Lifestyle, having an active lifestyle where you're moving around and keeping yourself healthy is really, really important. And last of all, but not the least, of course, medications. Medications are extremely important to control congestive heart failure. I want to say that CHF pretty much is not curable. You can control it, you can slow it down, you can reduce the number of complications that can happen over a period of time. Next slide. So edema. So congestive heart failure causes edema, and this edema is like this excessive fluid which is just building up and retaining in your tissues. You're most commonly going to see it in your legs. So you start with like, well, my feet have started to swell up. My shoes aren't fitting as well. And now it's the ankles. And when you wear your socks, you've got these indentations of the socks where they stop. And then this is gradually causing the swelling to build up into your thighs. So your pants may not fit as well, and your trousers may not fit as well as they were fitting, or they're stretching. And then, of course, they climb onto your buttock area. You'll see, start to see a lot of, like I described, sheet marks. I've seen them really across the torso. And you know those people when they come into the hospital. They are filled up with fluid up till here, like just physically, externally is what I'm seeing. But there's a lot obviously going on inside the rest of the body. And when they're like up to here, I'm typically seeing that they've gained like 10 or 15 pounds of weight, which is all fluid, by the way, and none of it that we need. And of course, now where does this fluid go? It's going to go into every possible tissue that it can find itself into. And most commonly, you'll see it building up into the lungs. So a condition which is dangerous and is called pulmonary edema. And the lungs are so boggy with that fluid that we have no other option except to start emergency medications to start to flush out that fluid from the lungs. So one, the patient can breathe. So the pressure on the lungs doesn't impact the heart and make the heart even worse and cause complications, dangerous complications especially. Pleural effusion, and I think that you'll hear this from time to time, is the lining of the lungs. We've got two lungs and they've got lining. So they've got two linings. One is the inner, one is the outer. And you'll actually start to see fluid build up between the lining of the lungs. And we'll see it on x-rays. And sometimes we may need a procedure to actually put a needle through and tap that extra fluid out of the lining of the lungs. When you get into that situation, we know that more or less this is a permanent situation, that while you can remove some of the fluid, but over a period of time, we will start to see that fluid build up again. So that is not a good sign, in our opinion. Next slide.
Okay.
So the next thing I want to talk about is strokes, definitely another common disease that we see in our elderlies. What is it really? It's an interruption or reduction in blood flow to the brain. There can be different types of strokes. I know you hear all these terminologies all the time. The two main types are ischemic, related to a blockage, and hemorrhagic, related to a bleed. So the ischemic are of two more types. So that's thrombotic and embolic. So thrombotic is when you have a blood clot which really forms directly in the brain. So there's sluggish blood flow in the brain for whatever reason, whether it's anatomical, whether it's just like because of the structure of the blood vessels, or because of anything else that's coming from the body. But there's a blood clot which forms directly in the brain. And embolic is when there's a blood clot which forms anywhere else and actually travels to the brain and causes a blockage up there. Hemorrhagic, of course, is a rupture of a blood vessel, and it can be quick, it can be instantly fatal for many people. An example of, it's not a stroke, but an aneurysm, and I think you've heard of aneurysms before, which is like a balloon in one of the blood vessels of your brain, can be very similar to a hemorrhagic stroke. So the risk of like the bleeding that can suddenly happen, the rupture of this blood vessel. A hemorrhagic stroke is when there's just the blood vessel explodes and you've really got bleeding, which is blood in the brain tissue, which is not a good sign for the most part. In my opinion, and I think both can be very different, but I do find that hemorrhagic strokes have a worse, what we call prognosis, and patients do poorly over a period of time. TIAs, it's a warning sign for a big stroke waiting to happen. So these are short episodes of stroke symptoms, and these can resolve almost immediately within minutes to within hours to within 2 days. So typically TIAs are less than 48-hour duration, as we call it. But of course, time is of essence. And therefore, the symptoms that you need to watch out for, of course, is we call it FAST. FAST is like facial numbness. You suddenly wake up and you're not able, you feel like you've got a droopy face, You can't feel the side of your face. Typically, it's one-sided. You may start to notice that your lips are droopy. You may not be able to speak, which is speak clearly, something which you also call a hot potato speech sometimes. So speech may be affected, or that you can understand what the person's saying, but you're responding in what we call a whole rumble of words. So you know what the person's saying, but the words that come out of your mouth are not making sense. Or sometimes you feel you're saying something which is making sense, like in terms of a sentence, like this is a dog. That makes complete sense to me if I just hear you for the first time, but it's not pertinent to the situation that is. So there's a certain level of confusion. There's speech issues. Arms can be flaccid. You may not be able to move a limb. So definitely flaccidity, weakness, numbness, tingling could be symptoms. And of course, time is of absolute essence in something like this. So the risk factors for strokes, I think we go back one.
Sorry about that.
Yeah, that's okay. So the risk factors for the strokes are things like hypertension, smoking, high cholesterol. I would also want to add diabetes to some extent in this. The first 24 to 48 hours is crucial. Um, I like to give patients a perspective of what this means. So first 24 to 48 hours is crucial. First 4 hours is crucial to decide whether a patient can benefit from this intervention, which they actually go in and try to extract the clot from the brain. So whenever we have what we call a code 3 coming into our ER, or it's usually we know whether it's a stroke alert, you will see that there will be people. We have a stroke team which is ready to go. People are ready, standing for the patient when the patient arrives in the ER. The paramedics will usually give us a heads up that this is a stroke alert. When the patient comes into the ER, we're immediately deciding if this patient can benefit from any surgical intervention. When I say surgical, it's mostly in relation to really going up into, it's like an angioplasty, a catheterization. You're going up and you're trying to extract the clot. You're also trying to see if this patient can benefit from thrombolytic therapy, which is really, can we push a medicine which can dissolve the clot so that the effects of the stroke are minimal to none. So a lot of it is very, very critical in terms of treatment planning, especially in the first 4 hours. The first 24 to 48 hours is crucial in it telling us whether we think this stroke is going to have some long-lasting effects. And therefore, the treatment and rehab goals are always, you want to minimize the permanent damage as much as possible. You want to reduce the physical, perceptual, the psychological, and language deficits, because obviously our brain controls everything. And to not be able to perform the things that you were able to do till yesterday can be very devastating to patients. So the effects of CVA and stroke. So, I have the opportunity to see this in my patients over years and years. And really what I see most of it is the psychological impact that happens as a result of not being able to do the things that you were once doing. Definitely the physical impact is huge. I say this to my stroke patients: the first week, the first 3 months, and 9 months, very important. It's really like first week, 3 months, 6 months, 9 months is how I put it. But if you really kind of shown, the maximum improvement that you really see is in about 6 months of after having suffered a stroke. So the effects of the stroke can be physical, of course. It's emotional roller coaster, the depression that sets in. Initially, it can be confusion. And then it can be, as you improve from the stroke and the confusion improves, you really kind of realize that things are not the same as they were before. The cognitive deficits, the inability to be able to perform a simple task that you were able to do, something like cooking or writing out a checkbook. Communication deficits. One is that you're really you have a poor speech but can understand everything. One is you have a good speech and cannot understand, but still cannot make sense of what the other person's saying. So it can be pretty devastating. The maximal recovery is first 3 months. I would say 6 months is the absolute cutoff point that I see in my patients, but I always go first week, 3 months, 6 months, 9 months. And that's really the trajectory. I get an opportunity to see how these patients are doing outpatient. And that is my experience, that if you can recover well in the first 6 months, you're good. Um, Caregiving role. As a caregiver, you end up being the advocate for your loved ones. You're going to be ending up providing for a lot of physical needs, including personal hygiene care, which I can tell you can be very, very devastating to patients themselves. The fact that they were able to take care of themselves previously before and now have to depend on somebody to put on a diaper or change them or wipe them can be very, very tragic and sad by itself. And of course, you want to be the one facilitating communication between the medical teams and the patient, and of course, other family members and friends. So you're going to be their spokesperson for the most part. Next slide. So, cancer, big one. I see it all the time, especially with palliative care. Goals of cancer care: prevention, recognition, treatment. There are so many tests available, screening tests, which are available to prevent cancer. And I highly recommend that everybody do the things that are needed on time, such as mammograms and pap smears and prostate PSA checking, prostate cancer checks, especially if you're a smoker and especially if you have family history. It's extremely important for you to be able to reach out to your doctors and say, when colonoscopies, for example, when would be a good time for me to get my screening test done. So, US, more than 13 million current survivors of cancer, worldwide more than 30 million. The most commonest cancers we see are lung and breast for the most part, both luckily, and prostate, both luckily actually very treatable cancers. So we've seen these are cancers which are breast cancers now fast called curative. Treatment is available for that. And even lung cancer has come up with some remarkable therapies. And there are lots of good options now compared to how we were previously treating our patients. Good immunotherapy, things we call targeted therapy, molecular therapy, all very great options. So assessment criteria, of course, the type of cancer that you have will be done with a biopsy and imaging study, something like a PET scan or a CAT scan, the location of the cancer and whether it has spread anywhere else. That defines how well we think a patient is going to do. Well, I'm going to talk about that in a bit. I don't always go with the stage, from a palliative care perspective, I want to say this. I don't always go with the stage of the cancer because for me, how well a patient has been doing prior to that, like so functionally active, is of paramount importance. Of course, the medical diseases that they have also affect and influence the treatment options. So what are the treatment options? Surgery is definitely one, chemotherapy and radiation. Now, I know we hear of all these treatment options. Sometimes you may actually need to do chemo or radiation before you do surgery, and then you kind of go back to chemo or radiation. And that really is, that goal is to shrink the tumor so that during surgery, you can actually get as much out and you can remove as much of the cancer cells as possible. Now, with all of this, there has to be a consideration for the elderly and or chronically ill. I have had patients who have come in with this diagnosis of cancer, 90-year-olds, 80-year-olds, even 50-year-olds, and have kind of said, I don't want any treatment. My life is what it is. I'm happy with what I have. And the last thing I would want to do is suffer through treatment. Definitely the perception, and it is a fact in some ways, the perception of chemotherapy and how devastating it can be in terms of side effects is all there. It's true to a great degree, but better and better treatment options are available. So I wouldn't totally rule out the fact that if you're elderly, you do not want to consider treatment. I think it really depends on person to person. I think it depends on the comorbidities that the patient has. What are the other issues going on? Definitely a patient with late stage dementia, having been diagnosed suddenly with stage 4 cancer, I would say treatment does not need to be that aggressive treatment does not need to be an option. There's always one more form of medical treatment that I feel like patients should always advocate themselves for, or caregivers should do it. And that treatment form is no aggressive medical treatment, only comfort focused treatment. So always remember that, yes, you do have the option of saying no to any treatment that might be offered to you. That is totally your prerogative. It is your right, and it is definitely something that we should be respecting as doctors and the medical team. So pneumonia. I know Debbie touched on the vaccine. So definitely the four types of pneumonias that I see is bacterial, viral, fungal, and aspiration pneumonia. We'll talk about that, especially in regards to the dementia patients. Um, it is when your immune system is compromised because you have all these chronic medical problems and you are at a higher risk of catching an infection. Pneumonia, definitely the flu, the viral pneumonias that we see in the flu season have become more and more serious over the past few years. I want to put that out there. Bacterial, a lot of bacterial, viral pneumonias can actually end up becoming bacterial pneumonia, something which we call a secondary infection. You can have one or the other bites just by itself, but we also see viral infections which are not getting better, having now developed secondary bacterial infection, as we call it. And that can be even worse for a person who already has other medical issues. Complications can definitely be life-threatening. I did want to put out that before COVID hit the world last year, in terms of flu deaths, so flu-related pneumonias, we had almost 40,000 deaths over last season, not this season. This season, I think we did relatively well with the flu because we were so focused on our COVID. So I think those numbers are still going to come up. But the year prior, so 2019 to 2020, we saw 40,000 deaths in the US based on flu alone, and most of them were elderly people. So it is definitely out there. Highly recommend flu shots for our elderly folks. They are the ones who are suffering more because they have comorbidities like we talked about. The symptoms that you can see in these patients could be confusion and tired. Like I will have patients, family members call and say, Mom is just like looking tired. She's sleeping all day. And that by itself will be, okay, let's get a urine test. Let's get a chest x-ray. Let's get some blood work. Let's see where you are. So you don't really need to show classic signs of pneumonia, which is a fever, cough, which is green or yellow, shortness of breath. You can really show nothing at all. You can just be more lethargic. You can be sleeping longer. And these are all signs that something else may be actually going on, especially if nothing else has been going on previously. So you could be tired or weak. You can have a cough, which has a phlegm, which is green or yellow. You can have chest pain, shortness of breath, fever, chills, and confusion. So the treatment, of course, depends on the cause. Viral is about 50% of cases, like we just described how flu has been so predominant over the past 5 years, especially in the US. And it's mainly conservative treatment. Of course, if it's severe, then there are antiviral medications that we can give to treat the viral pneumonias. And usually, of course, rest, fluids, healthy foods. But when it leads to a secondary bacterial pneumonia, really talking about patients needing hospitalizations, needing antibiotics. So they may have finished a course of antiviral medication, something called Tamiflu, if you've heard of it. And then now they're like, well, she took a course, but she's still not doing well. And now she was doing a little bit better with the fever, and now has kind of developed fever all over again. And now she's got this cough, and it's foul looking and smelling. You want to consider secondary bacterial pneumonia, and you want to treat then these patients with antibiotics. Now, over a period of time, and really we've got what we call baby boomers now. So we have patients who are living longer and longer, and they have just really had this complications of having had pneumonia over the years, maybe some ongoing lung damage, and have had multiple rounds of antibiotics. And now we're starting to see, we'll be seeing it for years, the antibiotic resistant bacteria. completely complicates the treatment. There might really be only IV medications, if at all. So IV antibiotics which are working. So which really mean that this patient may need to be hospitalized to treat that pneumonia. A lot of times, these IV antibiotics may be for at least a couple of weeks, sometimes more. It just really depends on the situation. So you start to talk about how patients end up being in the hospital. My favorite information bit to give to people, to families, is that 1 day in the hospital for elderly people means 1 week of recovery back to their baseline, if at all. So if I have somebody who is, let's say, 80 years old, goes to the hospital for, let's just say, chest pain, simple chest pain, going to make sure there's no heart attack, and may not have a heart attack, but really spends the night in the hospital. One, the hospital is the worst place in the world to get any rest. You're going to be woken up a million times to get your blood pressure checked and blood tests done. And so now we're disrupting sleep cycles, the normal routine of this patient. And so 1 day in the hospital, that patient, that 80-year-old patient, will take 1 week to recover from just that hospitalization. So when you start to add the number of days that somebody's been in the hospital for whatever reason, and your expectation is that, okay, mom had pneumonia, and I think hopefully she'll bounce back in the next 2 weeks. That may not happen. I've seen this last for months and months, that mom is not back to the same person that she was. And really, unfortunately, it may be a permanent change, and which you'll see that she'll never go back to the baseline that she was. So remember that pneumococcal pneumonia causes about 40,000 deaths per year. We talked about it. Actually happened last year that we had flu, and then of course these secondary bacterial infections. Highly recommend vaccinations. The other causes are fungal aspiration. So fungal I typically see in like the Central Valley area, but we have seen that. And again, it happens out of being immunocompromised. If you have lung disease, something like interstitial lung disease or COPD, emphysema, then you can have a higher risk of having fungal pneumonias, which will require months and months and possibly lifelong therapy. So those are oral pills. Sometimes we'll do IV medications in the hospital, but really fungal pneumonias are difficult to treat and very complicated. Aspiration pneumonia is something that we see in our dementia patients, very common, when patients swallow food and push it down the wrong end because their muscles are not contracting the same way, because the brain, from a dementia perspective, is not pushing the right signals as to how to correctly swallow food. You can actually see food trickle down into the lungs. A lot of times we do have to do this procedure for food which is stuck inside the lungs, a procedure called bronchoscopy, where we're going down, extracting the food out, cleaning up the lungs. All of this requires sedation for the patient, which totally throws patients off a lot of times. And then again, we know that this is not something which is going to stop at just one episode of an aspiration pneumonia. We see patients, what we call silently aspirating. So you have patients who you think are eating food, but that, that slight cough, that pocketing, you find food in their mouth after some time, like maybe minutes, or maybe just taking a really long time to swallow food, very high risk and cues for aspiration pneumonia. So I would highly recommend that you watch out for that for your loved ones. I also, let me quickly also bring, come back to the fact for aspiration pneumonia. I have to say, we have Band-Aid situations, Band-Aid treatments for aspiration pneumonia. We can treat it at that point, we can control it to some degree. There is no guarantee that it's not going to happen in a few hours or the next day again. And I also want to put it out there, and I'm happy to answer questions to that. Feeding tubes are not an option for treating aspiration pneumonia or preventing it from happening. It actually has the same high chance of causing aspiration, now down from the wrong end. So it's like food which is like trickling up again because the muscles are weak. So I do want to bring that up. I know sometimes we want to consider feeding tubes for our patients who have dementia and have aspiration. It is not a good option.
Okay. I'm really glad you brought that up. That's really important. And then later on in the presentation, when you talk about the pulsed and talk about feeding tubes, and yeah, I'm glad you mentioned that. And talk a little bit about dehydration. It's really common in the elderly, and in fact, it's one of the most frequent causes of hospitalization after the age of 65. But the good news is that this is one of the ones that's very treatable and even preventable. So according to a physician at the Baylor College of Medicine, quote, the rule of thumb is, if you're thirsty, you're already dehydrated, end quote. But that's a problem for the elderly because we tend to lose our sense of thirst as we age. And our appetites decrease. We tend to eat less. I'm actually waiting for that to happen. Hence, we get less fluids from our food. We lose fat under our skin. Again, waiting for that to happen, which reduces our insulation, making us more susceptible to temperature changes. And some medications, especially those that cause diuretics, can make us more likely to become dehydrated. Signs and symptoms, like those of many other treatable health conditions, can be virtually identical to dementia symptoms. I remember one time when I was severely dehydrated due to poor judgment on a really hot day. I was so disoriented that I couldn't figure out how to get out of a parking lot, and I clearly should not have been driving. The most common signs and symptoms of dehydration include persistent fatigue, lethargy, muscle weakness or cramps, headaches, dizziness, nausea, forgetfulness, confusion, deep rapid breathing, and an increased heart rate. You can see by looking at this list of symptoms, these could be symptoms for a lot of other things and a lot of other more serious things. So some of you, like me, may have experienced these symptoms after physical exertion, especially on a really hot day. So the most important way to prevent dehydration in elderly adults is to make sure they're drinking enough liquid. Seniors and all adults should drink at least 48 ounces of fluids, such as water or non-caffeinated beverages daily. I noticed that my mom never drank water, probably because her generation didn't develop the habit of walking around with water bottles like we do. But I discovered that her reason was that she didn't want to have to keep going to the bathroom, especially at night. Now, she drank coffee and Coke all day, so she thought she was getting plenty of fluids. But actually, that was counterproductive because caffeinated beverages can cause frequent urination and promote dehydration. So try to keep water readily available, especially if you're caring for someone with mobility issues. Now, you may have heard that we need 8 glasses of water daily, or 64 ounces. But Hope's dietitian told me recently that especially for the elderly, we need to shoot for 48 ounces. That tends to be more realistic. And then we want to add water to the diet in other ways. So if they don't like the taste of water, try using powdered drink mixes that flavor the water but don't add any excess sugar. Or you may have seen the recent ads for Pedialyte. This is available in many varieties. Actually, it's designed for adults. So you may want to check that out. Again, keep an eye out for added sugars. Soups and broths are another good source of fluids, but be sure that they're low in sodium. And then, of course, water can be found in many fruits and vegetables. So including them as a part of a nutritionally sound daily diet will help with staying hydrated as well. So include fruits like melons and berries, apples, oranges, and peaches. Now, vegetables such as lettuce, cucumbers, celery, and cauliflower are also good, but sometimes these vegetables are harder to digest, and they may cause some gastrointestinal discomfort. So you need to just keep an eye out for that. Now, inadequate hydration can also affect our skin, and Dr. Multani is going to talk about that next.
So, great. So skin changes. I mean, I see so many patients who come into the hospital again with bruises, with just, and we put in IVs through them, and here they are just kind of easily bruising and looking really, really like beaten up, and it can be concerning a lot of times. But I have realized over years that A lot of these skin changes happen, one, because we're all aging, number one. There's a lack of fat, which is the layer underlying underneath the skin layers, which actually helps to prevent the impact that, that younger people don't face as much. Reduce circulation, of course. Increased healing time, just poor circulation causing increased healing time, and the bruises can stay on for weeks and months sometimes. And then, of course, very, very fragile superficial blood vessels, which are on the top layer of the skin. It also happens because of medications. So a lot of times we'll see patients who've been on steroids for a really long period of time, or have had a smoking history for a very long period of time, many years. These are all like classic presentations of patients who I feel like they bruise very easily, or that we're seeing that they start to develop bed sores very easily just because there is no added buffer system in their body. So the protective measures are really, of course, sunscreen and protective clothing always. So the skin is one organ of the body which actually deflects. It just literally the sweat that can happen, and that patients sweat without even knowing it a lot of times. But we're really losing most of our water content in the body through our skin. Especially if you have like exposed skin, and especially if you're elderly, you will see that elderly people tend to dehydrate much more faster, just because this is like the perfect organ for them to deflect off all this extra fluid. So sunscreen and protective clothing is extremely important. I always recommend full sleeves for patients stepping out in the sun, just older patients, just because it's very easy to lose water this way. Regular skin checks, especially for skin cancers, very, very important, or precancerous conditions. Um, Application of moisturizer, of course, keeps the skin moist, allows for less number of bruises and cuts to happen. Foot care and diabetes management. Once a year, you want to go to your podiatrist and have yourself checked out for any bunions, non-healing sores, the numbness and the neuropathy that can happen with diabetes, and you're not realizing that you're actually starting to form sores in your feet. And definitely avoiding smoking, big, big thing. Smoking cessation is a big thing in having just good skin over the years. Genes always help. Genes always help. I've seen ladies with absolutely beautiful skin, and that's so much of it is genetic. And but then when you start to see medical problems come in, you will see the change. You'll actually see the difference in that. So UTIs, urinary tract infections, and pneumonias. Two big things, especially with our dementia patients. So urinary tract infections, very commonly in the elderly, mostly bacterial infections. There is only bacterial infection. And the reason is this. You've got a bladder, which contracts when it needs to go. A urinary bladder needs to go to, you need to go to the bathroom, it's going to contract, and it's going to flush all this urine out. When urine tends to, we've all got good bacteria in our bladder. When urine tends to sit in our bladder, one, because our brain is not giving our bladder the signal that we need to go pee, then all this bacteria, the good bacteria, gets into an overflow mode. And now there is too much of a good bacteria, which actually is a bad thing. And that's what brings on the urinary tract infections that we see in patients. And so the causes are, of course, the loss of muscle tone. It's not contracting as well. Urinary, so you're retaining the urine. Incontinence is one thing. So if you are bowel incontinent, you can actually cause urinary tract infections because of feces and stools just being in that area. And poor hygiene practices, of course, for pretty much the same reason. The symptoms that I see in urinary tract infections can be actually nothing. So you can have patients who are just confused, agitated, something's bothering them, sleeping longer. So you can have like absolutely zero specific symptoms, and then something's not quite right and you can't put your thumb on it. And or you can if you get lucky. But I feel like elderly patients just rarely do they present with this high grade fever and chills, but it happens. But more or less we see the really subdued symptoms in them. So it could be painful or frequent urination. You want to go to the bathroom again and again, and yet when you go, you feel like you don't have a good enough flow, or you're starting to now see blood or really dark colored or foul smelling urine. Um, you have this urge to urinate, but you're unable to do so. You start to become confused or agitated. You start to become weaker. When you get up, you're feeling dizzy or lightheaded, and you may have a very low grade or no fever at all. Um, Treatment is definitely antibiotics for UTIs. Now, some people need what is called suppressive antibiotics, which basically mean instead of the usual dose of antibiotics that we might give patients, we might give like half the dose. So if it's a pill, which is 2 times a day, we might just give one pill. So 2 times a day for 7 to 10 days, we might give one pill for the rest of your life. Just because if you have a tendency to have a frequent urinary tract infections, we cannot completely cure UTIs, especially in the elderly, but we can suppress the symptoms that can actually cause you to become sicker over time. So it keeps the number of the bacteria at a decent, acceptable level where a full-blown infection is not happening. So you can always talk to your doctors about that option. Of course, you want to talk to your doctors about incontinence medications also. So, there's something which is called an overflow incontinence. You want to make sure that you have the ability to pee when it's the right time to pee. A lot of times we've got this neck of the bladder, we've got the sphincter. The rest of the bladder wants to contract and push this urine out. But the sphincter, this muscle out here, this ring out here, for some reason decides it doesn't want to do that. It can happen very commonly with dementia patients. And so the neck is tight, but the bladder wants to contract, can create a whole lot of issues. So having an medicine for incontinence can actually help to contract the bladder correctly and push that urine out. So next is arthritis. So arthritis, definitely different forms. The commonest forms we see in our elderly patients is osteoarthritis. So just age-related degenerative joint disease, happens over years, causes disabling physical aspects of the joints where you can't actually grasp and do things as you were able to do before. You can have joint pain, the swelling. Swelling can actually cause like fluid to build up in the joints. So effusions, as we call it, and we can actually feel it in our patients. Stiffness, tenderness, change in motion, warmth, redness. I cannot tell you how many times I've seen patients who actually have severe arthritis in their hands and over a period of time develop problems in their elbows and therefore their shoulders, just because this is all reflected. So it's all referred to the back, to your main joints. And if this is affected, then your neck is affected. Your neck is affected, your spine is affected. It just becomes an overall issue. So really treating arthritis is a very, very important thing. You might think you've got one problem, but over a period of time, you will realize it'll stop you from moving, it'll stop you from your activity, you'll become more sedentary and more problems can happen. Rheumatoid arthritis, of course, is a form of autoimmune disease, and we see that in our elderlies. A lot of our patients are on strong autoimmune therapy just because they need to keep these symptoms at bay. Gout, see it very commonly in the men. It's a form of arthritis again. And then, of course, there's management and treatment options available for that. I always want to come back to the food, the lifestyle modifications. So food and activity always play a good part in improvement of these symptoms. You want to identify the food that works for you, that doesn't work for you. You want to be active, and then of course you want to take medications for it. You might not just need short-term, you might need actually long-term medications for it.
Okay. Dr. Multani has mentioned dementia a couple of times, and very common in the elderly, as we know. It's estimated that 1 in 3 seniors dies either from or with Alzheimer's or another dementia. But we're not going to really spend a lot of time on this topic today, mainly because we've already dedicated 3 webinars to dementia as part of our Living with Dementia series. And in case you missed them, these past webinars are posted on our website. So today, I just want to mention what your role as a care partner is if your loved one starts exhibiting signs of cognitive decline, such as confusion, disorientation, memory loss, not understanding, communication. So first, we always want to check for medication-related problems. Um, Sometimes a nutritional deficiency can cause dementia-like symptoms. A friend of mine contacted me recently because her mom's dementia became suddenly much more pronounced. But a simple blood test revealed that she had a treatable potassium deficiency. It didn't cure her dementia, but it took care of the new and extreme symptoms that she was exhibiting. Always check for underlying medical conditions like UTIs, dehydration, depression. All of these can cause dementia-like symptoms or worsen existing symptoms. With my mom, she had chronic UTIs. She had no other symptoms with the exception of her dementia would get very suddenly worse. And then that was kind of the red flag. Okay, let's check for the UTI. If you're starting to notice, cognitive decline changes, right up front, make sure that all legal and financial matters have been addressed, especially powers of attorney and advanced healthcare directives. You want to be sure that your loved one is able to sign these documents while they're still able to understand. Because if you wait too long, going to court to establish a guardianship is brutal. So you may want to schedule a cognitive or neurological evaluation as soon as the suspected symptoms begin getting a little bit more severe and interfering with your loved one's daily functioning. And again, please check out our website for our Living with Dementia program. And by the way, we're doing another dementia webinar on June 10th. So the mental health and well-being of your loved one is just as important as their physical health. So just as diseases can lead to depression and anxiety, mental health issues can produce physical ailments. So depression is really common in the elderly for so many reasons. Some are situational, some are medical. And sadly, we tend not to pay enough attention to mental health. Depression in the elderly is underdiagnosed and undertreated. So be on the lookout for the following signs. A big one is loss of interest in things that they used to enjoy, self-isolation, changes in their sleep or appetite, either too much or too little, changes in activity level, increased lethargy or agitation, sadness, or even talk of dying or wanting to hurt themselves. If you suspect that your loved one is depressed, you'll first want to rule out any medical condition, or here we go again, that medication-related problem, with a complete physical exam. And as part of this evaluation, patients can be administered something called the PHQ-9, which is a self-report scale for assessing depression. Some physicians may assess using another self-report measure called the Geriatric Depression Scale, and they're both pretty much the same. Treatment choices vary depending on the individual and type of depression. I always think it's a good idea to start with a non-pharmacological treatment. Relaxation therapy, music therapy has been shown to be highly effective, especially for patients who have dementia. Exercise therapy produces endorphins, feel-good chemicals. Even stretching exercises that can be done in a wheelchair or bed. And of course, anything that encourages socialization and reduces boredom can help immensely. Now, psychotherapy or seeing a mental health professional or a counselor may help if the individual is willing to talk with someone. And this isn't always the case with people in their 80s and 90s. And be careful with herbal remedies. They may interact with other prescription meds. And there are medications that can be highly effective in treating depression, but most of them take several weeks to take effect. So be aware of that. And the change in mood tends to be pretty gradual. And not all of them will be effective for everyone. All of the antidepressants and anti-anxiety meds need to be closely monitored by a physician, and don't ever just stop taking the drug. These meds change the brain chemistry, and stopping abruptly can cause some pretty serious complications, including suicidality. So it's always essential that you communicate regularly with your loved one's physician. So treating depression, it's a trial and error endeavor. Many treatments may need to be tried to find just the right one, whether it be a medication or a non-drug therapy. But most importantly, don't let depression go undiagnosed or untreated. Now, next up, Dr. Multani is going to talk with us about things to consider as our loved ones are reaching end of life. And before I turn it over to Dr. Multani, I just want to mention that I know we're close to 11:30, but I encourage you to stay with us and listen to this last part, because it is really, really important. If for whatever reason you do need to leave before we finish up and before the Q&A, just make sure that you complete the evaluation that'll pop up as you're leaving. So Dr. Multani, it's all yours now.
Great. So my favorite topic, right? Like palliative care. So palliative care is for patients who have serious medical problems, and the focus is a quality of life as well as a quantity of life perspective. So how can we help you live as well as you can for as long as you've got under the circumstances? So palliative care can be months, well, I say months, I say weeks to months to years before somebody might actually need the end part of palliative care, which is usually hospice. And I'm happy to talk about those differences. So when we start to see a change in the patient's functioning, if things have changed from where the patient is not the same person as they were 3 months ago, 6 months ago, and or that they've had a drastic sudden event on top of everything else that's going on, how would they like to have the rest of their life treated? This is a question that comes up when we talk to our caregivers as well as our patients, and definitely is a difficult conversation to have, but it is one of our most crucial conversations ever. So when you start, I always say this to patients, I might meet them for the first time, and here I am trying to spend time to kind of figure out what's going on with them from a medical perspective. But you as caregivers are the ones usually who are in the patient's life day in, day out. And sometimes you may not really realize what's going on, except if you step backwards and say, okay, yeah, mom was driving 3 months ago and she's not doing that anymore. That might be a thing. Or that you might actually start to notice like subtle changes that are going on. The 12 hours of sleeping every day is now becoming 16 hours. The full plate of food is now becoming half a plate. Those are subtle changes that you'll start to say, mom's clothes are fitting looser now than they were before. So when you start to see this, you know that that patient's disease is advancing. And if the disease is advancing, if I can see this now, what should I expect next? So what do we see in the coming days or weeks? This is something that a palliative care physician can actually walk you through the process of and kind of say, okay, if we're seeing the first urinary tract infection today, I won't be surprised if we see either a pneumonia or a UTI in the next few months. You know, a mom might become more incontinent. You're going to end up needing, she might become not just incontinent of bladder, but incontinent of bowels. And when that happens, there's a higher risk of more infection. You might start to see bed sores coming up. We talk about, of course, when you see your doctors, we talk about suggesting tests. And I think the important question to ask is, what are we going to do with this information? I always tell patients that once you get your information about how useful this test is going to be, ask yourself, are we going to do a test for which we plan to do nothing about, especially if it is going to push mom through a lot of trauma to get this test done? And or if you're going to say mom has late stage dementia and now she, let's say, has cancer, do we really need to, we took her to the ER because she wasn't feeling well. We had a CAT scan done, which shows a large tumor in her lungs, which is more than likely cancer based on just the images. Do we really need to get a biopsy to figure out that she has cancer? Because even if we get a biopsy and figure out she has cancer, do we really want this treated? Are we going to have her go through this treatment? So I think these are all questions that you want to ask the doctor. Will the treatment be, what is the value that the treatment's actually going to bring to me? Is it going to make her comfortable, as well as increase her lifespan, as well as kind of really help her feel better overall? Then I might consider it. But if it is going to be that the treatment is going to be harder than the disease itself, then I might just end up, mom might just end up dying before her time is up because of the treatment. So at that point, you want to ask your primary care doctors or specialists, is it time to consider palliative care or hospice care? The difference between palliative care, like I said, is palliative care is months to years before somebody might actually need hospice care. Hospice care, technically, definition of per Medicare is that you have less than 6 months to live. So if I look at a patient as a palliative care doctor, I certainly have the expertise to evaluate. I always say I might be dead wrong, but I always say we have been given the training tools to evaluate if this patient has less than 6 months. And if that is true, then I might want to recommend hospice to my patients. So goals of palliative care: we help our seriously ill patients feel more comfortable. We prevent or treat symptoms and side effects of disease or treatment. We provide relief from chronic conditions. And I wanted to bring up a point that Debbie had brought up right in the beginning, and that includes, what does that mean, relief from chronic conditions? It really means that we're looking at the patient from head to toe. I usually do a 90-minute evaluation on my patients, and we'll be talking about what are the physical symptoms. I ask everything from head to toe: dizziness, headaches, eyesight, hearing, down to your toes. And I go through that whole assessment. Then I ask what the patient does in the whole day. So describe to me from the time you woke up to the time you slept. What's your level of activity like? Tell me what you're eating in a day. I roughly do a calorie count in my head. I do a fluid intake in my head and say, okay, this is how much it's going. Are you able to put on your clothes? Are you able to step into a shower? Are you able to cook food? So something which we call ADLs, activities of daily living, and then some really specialized ADLs like driving, financial stuff. So I evaluate all of that. Then we talk about caregiving resources. Who's in the house with you? Who's taking care of you? And if you're not taking care of yourself, and if you're not taking care of yourself, I usually turn to the caregiver and say, okay, what is it? What are the challenges that you feel as caregiver? And then, of course, we'll talk about advanced care directives and post forms, which we'll come to in a little bit. So when we start to talk about that, then we'll come up with a plan and say, okay, these are the initial challenges that I see. These might be, I look at medications. So coming back to what Debbie initially said, I simplify medicines, especially towards the end of life. I strongly believe, I feel like patients will come to me. The max I've seen is 62 pills a day, which I think is a lot. I find it difficult to take one pill a day if I had to, but 62 pills a day for an elderly person who are trying to get all these medicines down, it's incredibly sad. So I like to simplify medicines. Like Debbie mentioned, the Lipitor, I'm going to ask my dementia patient who has lost 20, 30 pounds of weight through the past year, or maybe has a cancer diagnosis, and say, is this cholesterol medicine really going to improve your quality of life? And is it really truly important for you at this point? So I start to look at medications and say, what is it that we can do without? What is it that we cannot do without? I'll obviously interact with the specialists who are involved. I might reach out to the primary care doctor or the cardiologist and say, hey, by the way, I just wanted to bring up that I did recommend stopping the Lipitor just because I think patient is end of life and I don't think that it might benefit from this medication anymore. It just allows them to experience lesser side effects, eat better, feel better, move better. So once we've done this, I also very importantly talk about spiritual and religious preferences. I feel like that has such a huge part in a role to play in how patients perceive their end of life, or how caregivers perceive end of life. And I think it is really important to evaluate the psychosocial aspects, the emotional aspects, the spiritual aspects of somebody's life, because a lot of as caregivers, a lot of our experiences that we've had with our loved ones will impact the decisions that we'll take for ourselves and other loved ones in the future. So you can imagine that if mom is 95 and has lived a full life, but has also had these really, really intimate experiences with people that she may have cared for, might be a husband, might be a sibling, might be her own parents, all of that is impacting how she's doing currently. So remember that we continue, palliative care is for patients who are continuing to seek active treatment. It could be cardiac treatment, it could be cancer treatment, but it could be dementia treatment. It does not have any specific timeframes for diagnosis, treatment, or end of life. We can really start, we see a lot of patients who are super anxious with a stage 2 diagnosis of breast cancer, let's say. They might be young, so age has no factor, or they might be in just like severe pain due to a treatment that they may have had, or maybe a tumor which is bulging out. It could be just many different things. So there's no specific factor as to who could actually qualify, but usually in our experience, we are taking care of seriously ill patients. Next slide. Oh, my favorite video, and Debbie's too. So Debbie is going to play this video, which I think really gives a pretty clear perspective on what palliative care is about. And we'll talk more about the details after this video. I know we're running a little bit short on time, so I want to make sure that you get to see this video.
You are a bridge. It's true, or at least it's a good analogy. When you're healthy, when the bridge is sound, you can handle anything. Cars, trucks, trains, all the bumps of life, no problem. You are set. But if you're facing a serious health issue, something like kidney disease, lung disease, or cancer, the bridge starts to falter, cracks appear, and pretty soon it's hard to withstand all that traffic that includes your own medical treatment. And that's where palliative care comes in. Palliative care is a specialized form of medical care specifically designed for people with serious illnesses. Its main goal is to improve your quality of life by providing relief from the symptoms, pain, and stress that are an inevitable byproduct of both the disease and the medical intervention. In short, palliative care provides support for your bridge. And when a bridge is in trouble, there is nothing better. Now, palliative care, just like construction, is a team effort. It takes doctors, nurses, social workers, and other specialists all working together with your physician to realize that extra layer, the layer that can make all the difference. It's a treatment method that makes sense at any stage of life and at any stage of an illness, because it's never too late to lessen the burden. So, next time someone you care about is facing a serious illness, remember this bridge analogy and be sure to consider the enormous potential of palliative care.
Very, very important, pulse forms. I'm going to bring it up because I feel like I always carry it here to show my patients. But pulse form, extremely important. I love advanced care directives. I have nothing against advanced care directives, but I just love my pulse forms. Advanced care directives are for patients who want to designate when they're in still having the ability to make decisions. They want to designate who is going to be their decision maker, especially if things are not going well for them and they're at a point where they cannot mentally make those decisions. So that's really listing out the 3 people roughly who can help make that decision for them. It's very obscured, in my opinion. It's very obscured, but it kind of says, I wish to prolong life, do not wish to prolong life. And that can be very non-specific, which is where the pulse form steps in. And I talk about the pulse form because I think as a doctor who works in the hospital, it is extremely important to be as specific as possible in terms of medical preferences, medical treatment preferences. So we'll go through this. This is, of course, it's called the physician's orders for life-sustaining treatment. Other states call it MOLST. We call it POLST. It's a very specific down to like absolute like details in terms of what medical treatments you might want. It gives seriously ill patients and their families more control towards the end of life. Now, I want to make it very clear. I say this. If you're a person after having received information, if you're somebody who says, I don't care, I want every medical treatment option available out there and want everything done, this form is not for you. And it's okay. I say this in palliative care, there's nothing good or bad, there's no right and wrong in the decisions that you take for yourselves or for your loved ones, as long as you understand the good and bad and the advantages and disadvantages of treatment. If despite having heard that, you feel like, no, that's the way I would like to go, I would like everything done, you do not need this form. You need this form, especially if you do not want one particular form of therapy. It may be CPR, it may be feeding tubes, it may be whatever. But if you feel, especially, that you do not want CPR, you need to complete this form. So we'll talk about it. It's a legal document. You sign it, I sign it, becomes a legal piece of paper. So our nurse practitioners and our MDs, we all sign this form, and we can even do it online. So now I know in the age of telemedicine where we're doing these virtual video visits, I can actually send a code on the patient's phone, and the patient will get a spot on their phone. It turns into a writing pad. You can sign out there. The form is immediately available to you electronically if you so wish, but there are the e-polls that we are filling out nowadays, just because it has been difficult to see our patients more face-to-face. Of course, hopefully that's changing now. It prevents unwanted and ineffective treatments. It reduces patient and family suffering. And most importantly, this is it for me, it ensures a patient's wishes are honored. I only want to do what a patient would want for themselves. And a lot of it is lost in translation. The sooner you fill this form out, the faster you start to think about it, the better off you will be in terms of having made the right decision. This form can be changed at any point. You can tear it up today and you can do a completely new one. You can go into the hospital and say, honor this, but if you want to change something about what you're wanting in terms of treatment, you can change that. So the latest form is what really matters. We have had some tragic situations where even in the medical field, in our own office, we've had a situation where somebody's dad received CPR because paramedics insisted that was protocol because the post form was not available. This is the form that needs to be on every refrigerator or at least the side of the bed. Most of our hospice patients have that, but this needs to be readily available, especially if you're going to call 911. I also recommend that family members keep a copy of it on their phones, just in case, like if you stepped out, the patient steps out and something happens outside the house. Next slide. So that is what it is, the first page and the back page, really kind of talking about extra contact information, the details. I want to talk about CPR. So there are three parts to the form. CPR, hospitalizations, no hospitalizations, and the last part is a feeding tube. The first part is CPR. And what does that mean? If your heart stops beating, if your lungs stop breathing, if it looks like that you are dying. That's the only way to put it. If it looks like that you are dying, do you want us to try, being the big word, try to do CPR in an attempt to save your life? So data shows, and I'll talk about CPR is basically chest compressions, shocking the heart, and putting a breathing tube down into the patient's lung and hooking the patient up to a breathing machine, or life support as we call it. Now, a lot of times when a patient collapses in front of us or has a cardiac arrest, we may have no idea of knowing whether the patient's actually going to be resuscitable or not. Can we revive this patient or not? So we do it in an attempt to try to bring somebody back from dying. How often does that happen? Data shows that if you have a cardiac arrest outside the hospital, the chances of you coming back alive from that situation, by the time 911 is called, paramedics arrive, you start to get medical treatment, most importantly, oxygen, only about 4 to 5% people outside a hospital setting actually survive. How they survive and in what state they will be is a totally different question. When you start to talk about a cardiac arrest, which happens in the hospital, where everything is immediately available to you, that chance. So if I walked into a patient's room and that patient had just collapsed, and I start CPR right away without wasting 30 seconds, that patient has a 10% chance of survival. Again, how that patient survives is a totally different question. Now, remember that the brain damage starts to set in about 5 minutes. So if you're already finding somebody down, like you walk in and you find your loved one unresponsive, you don't know how long they've been unresponsive. Remember that at the end of 5 minutes, every minute after that, there's a 20% damage to the brain. And by the end of 10 minutes, which happens really fast, in 10 minutes, you've got a brain dead person. So keep those considerations in mind. I know there can be a lot of questions on this, and I apologize for the lack of time, but keep that information in mind when you're actually making decisions. What you want to add to that is the problems, medical problems that this person already has. Now, don't get me wrong, somebody younger, lesser medical problems, relatively healthy, hasn't really been in the hospital so much or in and out. It's worthwhile to say, yes, of course, I want CPR, I want things done. You know, those people have a higher chance of resuscitation and coming, like to be able to be revived. But there are people, elderly people, we do so much more damage to by actually doing CPR. We can, when we do chest compressions, we actually break ribs. It has happened in a 45-year-old patient of mine that I did CPR on. It happens all the time. So younger patients can have that. When we talk about older people, just one push, one shove on the chest can actually crack ribs. And when those ribs are cracked, they can actually puncture the lungs. And in my description, as I call it, we just about killed you. So we do not want, and I say this because when patients have an opportunity to think about their life and death options, as I say, if you've had a good life, you do not want to have a bad death. CPR can be torturous, painful, and full of suffering towards the end of life. So think about your options carefully. Think about it beforehand rather than being in a situation that you actually need, like right now, to need to make a decision. The second part, which is always the little bit more relieving part, is that yes, okay, let's just say you said, oh God, based on all of this, I do not need CPR. I want to be a do not resuscitate, okay? That doesn't mean do not treat. It doesn't mean you can't go to a hospital and be treated. I mean, if you look at it reasonably, how many patients have actually needed CPR in the hospital, right? Like when they go in for a medical problem, they're admitted for something. We don't have so many people kind of having that situation. Obviously, if they're very sick, that will happen. But for the most part, if you've been in a hospital 5 times and you've been out of it, the chances are that you really did not require CPR for a cardiac arrest. And so remember that cardiac arrest obviously is a fatal condition, and you're trying to be saved from that fatal condition. Think of it this way. When I think a lot of people worry about, if I choose do not resuscitate, I'm not going to have the treatment that my mom or dad would deserve to have or has the right to have. It's not necessarily true. Again, if the treatment is going to be more harmful than the disease itself, you really need to think about your options. So I always say, be relieved and be reassured of the fact that do not resuscitate does not mean do not treat. We'll do everything possible short of CPR when that comes. DNR patients can actually be in the ICU. They can get dialysis. They can get, a lot of other treatments that they might need. They might need emergency, really strong medications, IV drips, all of that. But if something was to happen where they needed a resuscitation, they would stop short of that because essentially it means that somebody's dying. The last part is, of course, the feeding tubes. If I'm not able to eat or drink by myself, do I want a feeding tube, temporary, which goes from the nose into the stomach, or a permanent feeding tube directly into the stomach, which could be a surgical procedure, to feed me for the rest of my life? Again, understand the challenges that can happen with that. Dementia patients tend to do very poorly with the feeding tube. Aspiration pneumonias are by no means preventable with the feeding tubes. It can help nutrition to some degree, but it does not stop the bed sores from happening, doesn't stop the pneumonias from happening. So especially from a dementia setting, especially if the patient is too weak and is bedbound or just lying down all day long, We have younger patients who do really well with the feeding tube, and at some point actually have the feeding tubes removed because they've done well enough and they have no nutritional concerns. So think about your feeding tube options carefully as well. And then once we've gone through it, you sign it, we sign it, it becomes a legal piece of paper. You keep the original, we keep a copy in our chart. Wherever the patient goes, like say to the ER should be able to pull this up. Next slide.
Dr. Multani, thank you so much. Let me put my video back on here.
I am really trying to answer the chat questions. I promise you, I'm trying. I'm just hoping.
Okay, you're looking at the questions.
You
Great.
can continue, Debbie. I'm going to start typing some of the answers in.
Okay, that sounds good. So again, Dr. Multani, every time we present together, I learned so much from you, and I can't help but think as I'm hearing you present how lucky somebody would be to have you as their palliative care specialist. So thank you so much. All right, so as always, we have an online resource list for you that supports and supplements everything that we've talked about. I don't expect that you can read this little teeny tiny thing on your screen, but I just wanted to give you an idea of what the pages look like. So all you'll need to do once these have been downloaded to your computer is to click on one of the blue links and you'll be taken directly to the website. You may not need this now, but somewhere in your caregiving journey, you may find that you'll be looking for this information. And what I've tried to do here is choose sources that I know are reputable and that have good information and that are pretty user-friendly. We do have some time for some questions, and I know Dr. Multani is writing answers to some of those. So let me stop the screen share and okay, and take a look at questions. There we go.
So I think I'm trying to answer as many as possible. I'm sorry, I wanted to take advantage of the time. I know a lot of vaccine questions. Just the last one I think I'm answering is, I do have a funeral to attend. Can I take my Moderna second shot early? How early? Oh, you wanted to move it up 1 week, you said. Is this possible? I don't think, I have to say, I think it depends on where you got your Moderna shot. If you were in that 4-week timeline and your shot you're expecting in 3 weeks, I feel like that may not be possible. And that is one, because of the regulations and the guidelines. 2, there is also data, if you want to be reassured, there is also data saying that the first dose almost already protects you by 90%. And so some of the recommendations are to actually push out even the second dose. Pushing it out by 1 to 2 weeks actually is okay. But again, check with your doctors. I'm not a primary care doctor, and I would love to answer vaccine questions, but I feel like this is something that in my experience that I've seen around me, and what I've been reading is that it's actually okay to push out your second dose a little bit. There is data coming out. And so I think the Pfizer, given the 3-week schedule, was okay to be 4 to 5 weeks out from what I last read. And I think Moderna is similar. Of course, there's been some shortage recently of vaccines. So that'll really depend on the provider that actually gave you the shot. But if you're worried about missing your dose, I don't think you could get it early. I really don't. But if you're thinking that you may just have to postpone it, then I think that it would be okay if you needed to postpone it by a week.
Okay.
That's just my opinion. Your doctor might have a different take on it, but that is what I've been reading.
Okay, so just to kind of sum that up, it's better to wait a week or two than it is to get the vaccination.
Yeah,
earlier.
I don't think that there's any added benefit in getting the vaccine earlier. I think what happens is over a period of time, your antibodies are forming and the levels are climbing. By the time you're actually getting the second shot, your first dose itself is actually protecting you really, really well already. So there've been all these, I think this is the first time we're offering these vaccines. There's all kinds of discussions about what this entails. So I feel like things will change in the future as we look into like the next, like, you know, when these vaccines wear off in our body and we get into the next batch of vaccines. So when that happens, things might be slightly different and the schedules might be different too.
Okay, thank you. One of the questions that I know that Dr. Multani responded to was from Bonnie, and it was the fact that she has the opposite problem with her dad in that he wants to drink too many fluids. And to be honest, even though it may seem kind of strange to us to think about it, too many fluids can create problems as well. So my recommendation on top of Dr. Multani's would be more of a behavioral one. And that is put the fluids in some kind of a water bottle that has one of those little straw things on the top, and make sure that you find a water bottle that kind of reduces the flow. You know how sometimes the insulated bottles, the water will just pour out. Some of them make a sip. So my suggestion with your dad is prevent him from gulping, from drinking really, really fast, and get him something where he can sip. It'll still meet his need. He'll still think that he's drinking a lot, but it can hopefully slow that down just a little bit. So, all right. Anything else? Any other questions? I think we've kind of done the ones in the box. So, thank you all for staying with us for so long. There was a ton of information today, and Dr. Multani just presents a wealth of really great information for us as caregivers. But also, as I'm listening to her presentations, I'm always thinking of myself and how can I, implement this information or infuse this information, into my life, into my habits, because it's good for all of us. So, Dr. Multani, do you have anything in closing that you would like to say?
Only that I love presenting with you. You are clearly a dementia expert, and I tend to learn a lot from you. So thank you for having me.